And you're listening to the lecture on management of patients with dermatologic disorders. At the end of this lecture, you should be able to describe the management of the patient with a wound, pruritus, or a dermatologic secretory disorder. Should be able to discuss the management and nursing care of the patient with infections of the skin or parasitic skin diseases. Identify the management and nursing care of the patient with non-infectious inflammatory dermatosis, including contact dermatitis and psoriasis. Use the nursing process as a framework for care of patients with blistering disorders, including toxic epidermal necrolysis and Stevens-Johnson syndrome. And apply the nursing process as a framework for a patient with skin tumors, as well as identify management and nursing care of patients undergoing cosmetic and plastic procedures. Wound care for skin conditions depends on the type of wound, the amount of exudate, the wound bed appearance, if the wound is an acute wound or chronic wound, any previous types of treatments that were attempted for the wound to close and heal, and the presence of an infection, presence or absence of an infection. Wound and ostomy and continence care nurses can help with choosing the appropriate treatment. The physician does have to give the official order, but nurses often give recommendations. If you have a wound bed, so in general, if a wound bed is putting off a lot of drainage, then you want something that can control that drainage. If you have a wound bed that's dry, you want something that will help to moisten the cells so that they can replicate and proliferate. Obviously, if there's an infection, that needs to be treated. And the longer that you can keep a dressing on, usually the better. Every time you take that dressing off, you're exposing it to the air. You're also reducing the body temperature. And so then the body has to bring the wound bed back up to a good temperature before the cells can start to replicate. Pruritus is basically just itching. It can occur with or without a rash or a lesion or break in the skin. So you can have an itch and sometimes you can tell why and you can actually see something there that's causing the irritation. Other times you might not notice anything. It can also be the sign of an internal disease, an allergic reaction, or some sort of infestation. Itching occurs more frequently in older adults because of dry skin and the fact that they have more chronic conditions. As far as treating pruritus, you want to figure out what the underlying cause is, and you want to treat that. Patients who do have itching, especially if it's because of dry skin, they should avoid hot water baths. Instead, they should use warm or tepid water with their bath, and they should use mild soaps or even shower instead of soaking in the tub, because soaking can cause the skin to dry out even more. Apply lotion after they're done with the bath or shower, and don't rub or itch the area because that can cause abrasions and skin breakdown. The patient should avoid extreme heat. They can wear cotton instead of synthetic materials, and that will help relieve some of the itching as well. Acne affects up to 80% of the American population. Diagnosis includes both the H&P and then an actual visual inspection of the lesions and seeing if they have the characteristics of acne, and then also looking at the age. Treatment the goal of treatment is to reduce bacterial colonies, decrease the sebaceous gland activity, which causes the pores to become clogged, and prevent follicles from becoming plugged, reduce any inflammation that might be there, minimize scarring if the acne does go deeper into the dermis, and eliminate factors that can predispose the person to acne. There are topical medications that can be given, and then if that doesn't work, then there are oral medications, oral antibiotics that can be given as well. Some topical medications do have side effects that are pretty severe, so those need to be discussed with the patient as well as the family if it's someone who's under the age of 18. If they have mild acne, then they're just going to try something that's over the counter. The other medications, the ones that have the more severe side effects, potential for adverse effects and organ damage, those are for more severe cases of acne. There needs to be a fair amount of education and reinforcement on that education. There's no evidence that acne and a diet have some sort of association. So the myth that, eating chocolate's going to cause you to break out, having fried foods will cause you to break out, milk products might cause you to break out. There's absolutely no evidence that supports that. Patients should not pick at their acne. They should not squeeze or pop their pimples because this can make things worse. It actually makes the skin surrounding the area darker and can lead to more scarring than what would happen if they just left it alone. Lotions can clog pores, aggravating the acne. So can certain shaving creams and cosmetics. So just washing the face twice a day, drying it, and then putting on the acne treatment. Ointments or creams is all that the patient should do. They really shouldn't put anything else on their face that they don't need to. There are different types of infections of the skin. They can be bacterial, viral, or fungal, and we'll go over each one of those in the following slides. Impetigo is a superficial infection of the skin. It's caused by either staphylococci, streptococci, or it can be a mixture of multiple bacteria. The bulla will form and then rupture, leading to red raw areas that ooze. It is contagious, and it's the exudate of the lesions that is contagious. And so once the area is open, it will form exudate, and then the exudate will eventually dry and make a crust. Because it is highly contagious, it can be spread by touch, so the patients need to be really careful. They shouldn't pick at their crusts or pick at the areas that are infected. If they do and then they touch another area of their body, they can spread the bacteria from one area to the next. They should avoid sharing towels, or washcloths. They should not be sharing any combs or any object that could be soiled with the exudate or the lesions. Good hand hygiene, meticulous hand hygiene is going to be vital. Treatment is usually a topical antibacterial therapy that lasts 5 to 7 days. Before putting on the antibiotic cream or ointment, the lesions need to be soaked and washed with a soap solution. And this will help to remove the topical bacterial growth. It will also help to remove the crust so that you can actually get down into the openings where the bacteria sit. Make sure gloves are worn anytime you're dealing with anything that the cleaning, the towels, the washcloths, the ointments. Make sure gloves are worn. Otherwise, it can be spread. Educate the patient and family on prevention, as well as spreading from one area of the body to the next on the same body, as well as spreading from one person to the next. Make sure everyone has their own towel, their own washcloth, which they should anyway. And avoiding the person who's infected needs to avoid contact with anyone else until the lesions are healed. And you see this a lot in children. You do see it in adults as well because it is highly contagious. Children with pacifiers, they'll get the pacifier ring around their mouth with impetigo, and like those pacifiers need to be thrown away. So if there's something that they use religiously, or like if you get strep throat, you're supposed to throw your toothbrush away. Anything that goes on and around that area, if it can't be cleaned with hot water to make sure that the bacteria are killed, then it needs to be disposed of and replaced. Herpes zoster is shingles. This is a viral infection, and it's caused by varicella zoster. The patients will complain of painful lesions. They will be in a lot of pain. The patient can get the virus, will get the virus, and it can lay dormant inside the nerve cells near the brain and the spinal cord for a long period of time. and then the virus will reactivate. It travels by way of the peripheral nerves to the skin, where the virus then multiplies and creates small blisters. Treatment would be acyclovir, valacyclovir, pain reduction medications, analgesics, corticosteroids can be given, triamcinolone can be given, they can take Tylenol. Also, you want to do what you can to help the patient to avoid complications. Give patient education. So they need to take all of their antiviral medication. They need to wash their hands before and after applying topical ointments and creams because that will help to prevent the spread of the infection. They also need to be educated on how to manage the pain. You can teach them diversion activities, relaxation techniques. They need to get adequate sleep, and they need a well-rounded diet. And that will help them heal. Fungal infections, there's ringworm, and this is the most common fungal infection. It's often seen on the head, the groin, the feet, and the nails, and diagnosis is done by skin scraping, or they'll use the Woods light to see. And whenever they put the ultraviolet light on and they turn the regular light off, the infected area will fluoresce. You can also get fungal infection in the hair, down in the follicles of the hair or in the hair itself. If they get it in the hair, then if it's in the eyelash area, the eyelashes can fall out. And if they get a fungal infection around their eyebrows can fall out as well. Hair can also fall out if it's in the scalp. As far as education, and make sure that you talk to them about medications. If they have oral medications, they need to take them until they're completely done. If they have a special shampoo, then they need to be instructed on how to use the shampoo from application to how long it needs to stay on before it can be rinsed. And then how often to do the shampoos. Topical agents, they should wear gloves. They should do good hand hygiene before and after. They need to use clean towels and washcloths every single day, and they need to clean their towels and washcloths in hot water to make sure that they kill the fungus, and they should not share towels or washcloths. If it's in their hair, they shouldn't share combs, so they should have their own set of stuff in the bathroom. Make sure that the skin is kept dry, and that will help to prevent the spread of the infection. Cotton clothing is best. As far as undergarments, it should be cotton because it breathes better. Synthetic underwear can hold in moisture. Tight-fitting garments can also hold in moisture, can aggravate the skin, and helps the fungus to grow and spread. If they go swimming, then they need to take their bathing suit off as soon as they're done. And then there's different types of lice. There's head lice, body lice, and then genital lice, or crabs is what it's more commonly called. The lice infestation can be anywhere on the body, and then its name is just depending on where the region is. But the lice will inject their digestive juices and excrement into the skin. That causes the skin to become extremely itchy. With head lice, on the top left, you are going to be looking for little nits, so these little white areas that are all over the place. And they're usually pretty close to the scalp. Those are the eggs. They hang out in the back of the head and behind the ears mainly, and then they can spread. If the nits are not caught or removed, they will hatch in about 10 days, and they will turn into these little bugs, which is right down. Here's one. Here's one. I don't know if you can see it all that well, but those are a couple. And then the actual lice will mature in about 2 weeks, and then they can lay more eggs, and the cycle continues. Head lice can be transmitted directly. It can also be transmitted by indirect contact. So it's important to make sure they're not sharing any combs, brushes, caps, hats, anything like that. Pubic lice is also extremely common. Treatment for head and pubic lice involves washing with a shampoo that contains special medication, and so you can use Rid or Nix. Those are the two most common. There's over-the-counter and prescription. The thing with head lice is that the bugs are getting resistant to the treatments, but they still do try them and they will still prescribe them. The physician will. After the shampoo, then you go through the person's hair. Very, very small parts of the hair, a little bit at a time. You go through with a fine-tooth comb that's dipped in vinegar, and you need to remove any nits. If they don't get removed by the comb, then you can just grab and pull the nits. But the nits need to be removed. And then if you see any dead bugs, those need to be removed as well. And you should go through the hair and check the hair for at least once a day for the next 2 weeks after you're done using the shampoo. If it is pubic lice, then you also, most of the time, someone who's diagnosed with pubic lice will also get tested for other STIs. Body lice is generally not on the body itself, it's generally on the clothing. And so most of the time they don't treat with body lice. They can give a topical wash, but they usually say just to strip all of the beds down, put all the clothes through the wash, vacuum. Anything that needs to be washed, no matter what type of lice you have, you should strip everything down. And it needs to be washed in hot water that's at least 130 degrees Fahrenheit. It can also be dry clean. Upholstered furniture, rugs, floors all need to be vacuumed. Combs, brushes, and helmets should be replaced. And anything that is of a cloth type material that cannot be washed needs to be bagged. And then it's kept in a bag for 2 to 4 weeks, just to make sure that all of the if there's any nits or anything, it gives them time to hatch, and then all of the live lice will just die. In here, the little red spots, that's where they're actually injecting their digestive juices and excrement into the skin. And so you'll notice all these little itty bitty red spots as well, and they're extremely itchy. Then you have scabies. This is an infestation of the skin by the itch mite. It is most common in people that live in substandard hygienic conditions, as well as those who are sexually active. It takes about 4 weeks for the patient to have symptoms from the time they are infested. Signs and symptoms include severe itching, and it usually gets worse at night. Visual examination of the site will reveal small raised burrows that are created by the mites, so they can be little slits or they can be little like half moons. Treatment, the patient will have a warm soapy bath or a shower, and this is going to remove any of the scaling or crusting that's around the site. The skin will then be pat dry to make sure it's completely dry and cooled, and then the medication will be applied to the entire skin from the neck down, so nothing on the head or the scalp. The medication will be left on for 12 to 24 hours, and then the patient will be told to bathe again. As far as education, it's the same as it would be for lice. So in the little pictures, this person has a lot of little bitty mites that burrow down, but all these red spots. Here is a close-up picture, and you can see right here that it's like a half moon. And they do scrapings as well for these. Okay. And then this just shows you the mites get on the skin and then they burrow down. And they'll stay down here, lay their eggs. And then they'll come back up and they'll leave and then they'll burrow more. Contact dermatitis or eczema is a reaction to physical, chemical, or biological agents. Most commonly, it's an allergic reaction or irritation that's caused by soaps, detergents. They can come in contact with some sort of chemicals, the extreme heat or cold. Um, I have a reaction to the powder that's in the gloves, so I can't have any kind of powdered gloves. Otherwise, my hands will break out pretty bad. Clinical manifestations, there can be itching, burning, redness, edema. The patients can actually get papules and vesicles that will ooze and weep. Their skin can become so bad that it cracks and it peels away. Treatment is to soothe and heal the skin, protect the skin, put protective ointments on there, remove whatever the irritant is, so identify and remove the irritant. And then keep the skin nice and dry and put moisturizer on it, ointments. They can get corticosteroid ointments, which will help with the swelling, and just do what you can not to get an infection. And there's psoriasis. Psoriasis most often involves the skin, however, it can affect the eyes, oral cavity, and joints. It is believed to be an autoimmune disorder, and it does have periods of exacerbation with periods of remission. Stress, trauma, infections, hormonal changes, and anxiety can aggravate the condition and bring on psoriasis at the exacerbation. And if they're having, if they actually have spots, it can make it a lot worse. As far as what you will physically see on an assessment, the scaly, flaky, silvery plaques that will appear in patches on the skin. And they are caused by epidermal hyperplasia. Psoriasis can be classified as mild, moderate, or severe, and it's based on the percentage of the body surface area that's affected. So 5% is mild, between 5 and 10% is moderate, and severe is anything greater than 10%. Complications for psoriasis are asymmetric rheumatoid factor negative arthritis. So it's asymmetric arthritis that whenever they do testing turns out not to be rheumatoid arthritis. Most commonly in the hands or feet, but it can also be in the larger joints. Generalized exfoliative dermatitis is another complication. As far as medical management, bathe with oils. So get in a tub that has oils in it, and that will soften up the scales. You need gentle removal of the scales, so no picking at the scales. The getting in the bath with the oils will help to soften those scales up. Oatmeal preparations also can soften the scales to help remove them, and then coal tar preparations can be used as well. After bathing and the gentle removal of the scales, then the skin is dried and topical agents are applied. Systemic therapy can be used. It's only used for severe cases because there are significant side effects. You can also have phototherapy if the topical therapy doesn't work. As far as the nursing process, you're going to assess the skin, look at the lesions, and note where they are at. You're going to look at if there's any openings, breaks in the skin, if you see any edema on or around the lesions. Look at the nail cap, then look at the nail in the nail bed, look at the scalp. Ask them about their joints and is there any pain. Look at their mouth, look in their oral cavity and at the mucosa to see if you see anything there. Look around their eyes and their conjunctiva. Ask the patient how they're doing, because the psoriasis can cause disfigurement and give them a very poor body image. And so you want to ask them how they're coping, psychosocial factors, family support, that sort of thing. Provide them with education once you've identified what their immediate needs are. Give them education about the disease itself, things that can cause exacerbations, proper skin care, proper treatment regimen, so they can't just put the ointment on. They need to actually clean and get rid of as many scales as they can before they put the ointment on, so that it can get soaked up into the skin and it's not just sitting on the scales. Talk to them about, not picking, not scratching. It should be very gentle removal of the scales. If they cause breaks in the skin, then that's a really good chance for an infection, because it will crust over and then scales can go over that, and whatever bacteria is in there will be trapped, and it will start to grow and take on a life of its own. Make sure they're using emollients in the skin that is not affected. Make sure they're not using excessively hot water and harsh soaps. Pat the area dry, no vigorous rubbing, and make sure they have good social support. Blistering diseases. Um, there are many, many different types of diseases that cause blistering. And so, burns can cause blistering, allergic reactions can cause blistering. Some of the bacterial, fungal, viral infections can cause blistering. You can have autoimmune reactions that cause blistering. So there's just so many different types. You want to figure out what the cause is and treat the cause the best you can. They should not be picking at their blisters. If they're have blisters because of bacterial infection, viral infection, fungal infection, then it can be contagious. So they need to watch about the exudate. Ask them if their blisters have any effect on their lifestyle. If it has functional physical limitations, if it has any psychological effects. Do they get these blisters often? How often? You can get all of that information. Have they had blisters on their skin before? What have they done before? Sometimes you can get blisters from trauma. Stage 2 pressure ulcers can cause blisters. So finding the underlying cause and really asking assessment questions that focus on the underlying cause can help quite a bit in getting them quick treatment and the correct treatment. If they have blisters in their mouth, they need to do meticulous oral hygiene, even if it's sore. So, like, you'll follow and the same interventions that you would for the stomatitis. They should avoid commercial mouthwashes that would cause a lot of burning. If their lips are dry, then they need lip balm or petroleum, Vaseline, just something to keep their lips nice and moist that, if ingested, will not cause harm. They can use a cool mist humidifier that can help to get rid of some of that dryness, especially if the air is pretty dry. They should take tepid or warm baths, not hot baths, and they should probably shower over bathing. If they have active blisters, then they can put powder on the skin, and that will help to prevent them from sticking to the sheets and causing shearing and friction. Watch for signs and symptoms of infection and look at the skin, the blisters, especially once they do open up. If they do open up, to make sure that there's no kind of an infection going on, you might have to do wound care. So, ensure they're getting proper wound care, that the skin and the blistered areas are being cleaned in between the treatments. Then you're not just taking an old dressing off and putting a new one on. And then make sure they're getting proper nutrition, adequate fluid intake, and they're getting their vitamins, minerals, and protein intake with their nutrition. Toxic epidermal necrolysis and Stevens-Johnson syndrome are both potentially fatal. They are acute skin disorders. Patients will complain of conjunctival burning or itching. They'll have cutaneous tenderness, fever, cough, sore throat, headache, extreme malaise. They can complain of myalgias of rapid onset, and then after those symptoms, they'll have rapid onset of erythema involving pretty much the entire skin surface as well as the mucous membranes. And both are extremely painful as far and can be external. It can also be internal, and the patient can develop ulcers in the larynx, bronchi, and the esophagus. Usually it's a response to a medication, so ask about any medications that they've had in the last 4 weeks. They can easily become septic. They can get multi-organ dysfunction syndrome or MODS, and then they can have choroidoconjunctivitis, which causes conjunctival retraction scars and corneal lesions, which can lead to blindness. So there's some pretty severe complications if they get either one of those. The initial treatment is systemic corticosteroids. Watch for any signs of an infection because they are at a great risk for an infection. Look for fluid and electrolyte imbalance, especially if they have MODS or sepsis, and then they're showing signs of shock. They will have delayed wound healing as well. They can get IVIG, and this provides rapid improvement whenever they have done it. The studies do show that the patients have a pretty good turnaround with it. Immunosuppressive agents can also be used, and protecting the skin is crucial so that they don't get any skin breakdown. Topical antibacterial and antiseptic agents can be used, especially if they have open areas. And the patients usually don't want a lot of things touching them, so a very light blanket is what they can normally tolerate. Skin cancer is the most common cancer. Frequently it's related to getting too much sun or being out in the sun without having any kind of protection. Sorry, I lost my clicker. Prevention, minimize sun exposure, wear protective clothing. So there are special UV protective clothing that can be worn. The long sleeves whenever you're going to be exposed to the sun for long periods of time, wearing pants instead of shorts, staying in shaded areas, those types of things can help. Wear SPF 15 or greater as far as sunscreen, and make sure you put it on 20 minutes prior to exposure. Reapply every 2 hours if once you do have sun exposure, and then anytime you get out of the pool or the ocean or any type of body of water where you're wet, dry off and put the sunscreen back on. Make sure it gets absorbed. Stay away from artificial ultraviolet sources such as tanning beds, and then do a head to toe once over skin inspection every month. There are benign skin tumors, and then there are malignant skin tumors. So here's a list of the different types of benign skin tumors. And then as far as malignant, there's basal cell carcinoma. This is the most prevalent type of skin cancer, but it rarely causes death. You will see it mostly on areas that were exposed to the sun, and it will start as a small waxy nodule. It can be shiny, flat, gray, yellowish. It just depends on the skin type. Recurrence is common, but it rarely does metastasize. And then there's squamous cell carcinoma. This is the second most prevalent skin cancer in the United States. And it starts out as actinic keratosis and then can form into squamous cell carcinoma. I'm so sorry. It's been a day. It can metastasize into the blood or the lymph system. It's less aggressive than the melanoma, which we'll talk about next, but more aggressive than your basal cell, which we talked about first. The lesions can be bleeders or they can be asymptomatic. And here's the different types. Your basal cell is on the left and your squamous cell is on the right. Treatment for both is a surgical excision of the tumor. If the tumor is large, then the patient might need reconstructive surgery. They might need grafting, skin flaps. They can also get radiation, photodynamic, or topical chemotherapeutic creams if the patient does not want to do surgery or for some reason surgery is not an option. If surgery is an option, then they can do a simple excision. They can do Mohs, they can do electrosurgery, cryosurgery, which is deep freezing. So there's different options, and the dermatologist will speak with the patient and decide what's the best option for them. Melanoma is another type of skin cancer, and it is present on the epidermis as well as the dermis. And it can be dark, blue, red, a mixture. It is irregular in shape. Patients can complain of the lesion itching. It generally grows pretty quickly and it does bleed and turn into some sort of an ulcer. And treatment would be an excision and then they can get chemotherapy as well. Superficial spreading of the myeloma is, the superficial spreading melanoma is in the first picture. And so you can tell, my little thing go, how there's pretty like irregular shape. And here, like this is the newer area that's coming, the lighter area is where it's starting to spread out. And then there are the darker areas, and those are probably deeper than some of the lighter areas. The nodular melanoma is here. Melanomas generally have two phases. They have a radial and then a vertical. During the radial phase, the cutaneous melanomas spread radially within the layer of the epidermis, and then during the vertical phase is when they go down into the dermal layer. And this is whenever metastasis can occur. So it probably started, if you're looking at the first one, probably started smaller, and then it spread outward and upward and downward. Treatment depends on the stage of the tumor because they will stage it. Surgical incision is for stage 1, and that's usually, other than surgery, they don't need to treat the area. Stage 2 or 3 will be surgical as well as most likely chemotherapy. Kaposi sarcoma is a malignancy of the endothelial cells that line the blood vessels themselves. So you have these lesions, they can be small, medium, large, they can be varying sizes, but they're dark reddish purple. They can be internal and external, and they can be painful. You'll see them a lot on patients who go transition from HIV to AIDS, and it is extremely aggressive for patients that have AIDS. As far as treatment for patients with skin cancer, assessment for the nurse, you're going to inspect the skin carefully, ask them about any areas that you see that might be suspicious, or ask them if they have notice any areas on their body that itch, that are more tender, painful. And, are they looking at their skin every month and doing the inspections? If so, Do they have any moles that have changed size or color or shape recently? Do they notice any new types of lesions or areas on the body where they have some that are just popping up? Ask them about how long they spend out in the sun. Do they use sunscreen? Do they wear long shirts and pants? Are they taking the protective measures that they need to? Ask about family history, because it can be familial. Any of their own history that they know of. If they have any tanning bed use, that's important. What their occupation is. Does their occupation have them outside a lot of the time? Or do they mainly work indoors? That helps quite a bit as well. If they played sports, whether sports outdoors or indoors. Because in addition to the games, they're practicing, so they tend to be outside a lot more. And most of the time don't wear sunscreen. Um, as far as interventions, make sure that they have analgesics if they do have pain. And you can talk to them about pharmacological and non-pharmacological interventions for pain control. Talk about diaphragmatic breathing, distraction, guided imagery. There are lots of different things. Heat, cold, anything that really can help them with the pain as long as it's not contraindicated for their disease process. Provide emotional support of patients who are diagnosed with cancer, especially on the skin, which can cause or can call for treatment that can leave them disfigured, that can make them upset. Make sure they have the correct information, and they can go on the internet. And with the internet, everyone nowadays is just trying to search their own stuff and figure things out. So ask them questions, ask them what they know, and make sure that what they tell you is accurate and correct and complete information. Find out what the doctor told them, make sure they understand what the physician told them as far as their diagnosis and their course for treatment. Have the family get involved, ask them if their family knows, make sure that they have open line of communication because that's going to be their support system. After surgery, they might need some sort of reconstructive surgery. They can have skin grafting, they can have flaps as well. They can have reconstruction surgery of the face if their basal cell or squamous cell carcinoma was on the face, and they can have a facelift as well, but that isn't related to cancer usually. Skin grafting itself is when they take a section of the skin, detach it from its own blood supply, transfer it as free tissue to the recipient site. And this is generally used when wound closure would interfere with function. So if they did primary wound closure, it's going to interfere with function. It can also interfere just visually, cosmetically, and they can use a graft. They can do the autograft, allograft, or xenograft. Autograft is taking the donor site is actually from your own body. So the patient's own skin is taken from one area of the body, put it to the next area of the body. Allograft is taken from another human, so same species, and then xenograft is from an animal, and it's usually a pig. Whenever you are taking care of these patients, you need to make sure you look at especially if it's an autograft, the donor site and the recipient site to make sure that they're both healing well. Make sure that they have no signs of infection, that both areas are perfusing well, no bleeding or hemorrhage from the recipient site, no like purulent drainage, foul smell, no necrosis. So you're looking for signs of infection like redness and swelling, and you're also looking for good perfusion. So is it pale? Is it cool to touch? Is it bluish, grayish, black? Those are signs that there isn't good perfusion, and that's something the doctor needs to know about right away. There are two different types of flaps. So a flap used to be, um, it is different from a graft. It can be tissue, it can be like epidermal, dermal, subcu tissue, it can be muscle, it can be bone, um, but there's usually an area that is still connected to the original site at some point. So it is the tissue that is surgically lifted up, but it's still connected to the original site at some point. A free flap, however, is a completely severed area of tissue, muscle, bone, vasculature that is completely severed and removed and put to another site. So they used to just have a flap, but now they have the pedicle and the free flap. And so the free flap is not connected. Facial reconstruction surgery is an option, and this is where they're just adding it, like if they had to take part of the nose because that's where the cancer was at, they're going to try and reconstruct and rebuild that area. Facelifts, that is definitely more cosmetic, and you can have cosmetic surgeries, and the facelift is just to basically your skin gets loose and kind of starts to sag, and so they pull everything up. It gets rid of the wrinkles. It can get rid of excess skin if there's a lot of excess skin. It can get rid of any type of folds, and afterwards the patient will be on vitamin C, and they'll take corticosteroids to minimize the edema. There are other types of cosmetic surgeries that can be done. There's chemical peels, and that is a chemical that's actually put on your skin, and then they remove the chemical and it removes the topmost layer of the cells. So that can be done. That's usually done, it can be done at a surgical suite, a plastic surgeon's office. They can give Botox injections, and that can be done at the plastic surgeon's office as well. There can also be laser treatment of the lesions, and these are precise surgical instruments, and what they do is they vaporize and excise the water-containing tissue, and it causes minimal damage, which means there's minimal to no scarring. Generally safe for people who do have bleeding disorders or for those who are being treated with anticoagulants, but it's only used for minor procedures. So if they have an ingrown toenail, keloids that need to be removed, wrinkles that they want to have flattened, warts that need to be removed, if they want to have a tattoo removed, then that's the types of things that you would use these lasers for. Generally, they use local anesthesia. They can do moderate sedation if they have to, but it's done at the physician's office. It can be a dermatologist office, plastic surgeon. It can be done in an outpatient setting as well.